Hello, in this video I'm going to be talking about less common or rare types of breast cancer. These include Paget's disease of the breast, mucinous carcinoma, medullary carcinoma, metaplastic carcinoma, angiosarcoma of the breast, and inflammatory breast cancer, as well as papillary cancer. First of all, I want to say it can be really hard to have a less common type of breast cancer because you see information and you're told, well, that doesn't apply to you. And you can feel sort of like you're in this limbo state where you're not one thing or another, rather you have an unusual, uncommon, or rare type of breast cancer. Before I go on, I want to invite you to subscribe to our channel. We're always putting out new content, often in response to your requests, so there's always something new to watch. I'd also love to invite you to go to Yerbba.com to get your personalized report. So let's start with mucinous carcinoma. Mucinous carcinoma accounts for fewer than 5% of breast cancers. This is actually a subtype of infiltrating ductal carcinoma, but it's different in a few key ways. Under the microscope, there's a lot of mucin in the ducts. Mucin sounds a lot like mucus, and it looks a lot like mucus. It's jelly-like. And for a tumor to be called mucinous, it needs to be pretty much 100% mucinous cancer. So if something's an infiltrating ductal carcinoma with mucinous features, that's not the same as mucinous cancer. Mucinous cancer is associated with a much better prognosis. If the size is the same, receptors are the same, and the lymph nodes are negative, as they usually are with mucinous carcinoma, the risk of recurrence is about half that of an infiltrating ductal carcinoma, sort of the standard infiltrating ductal carcinoma. So that's a good thing about it. One thing that's a challenge with mucinous carcinoma is that the Oncotype DX and other assays are not validated in mucinous cancer. So in general, we don't look at the results of the Oncotype DX assay, in particular, in people with mucinous carcinoma. It just doesn't bear out. And in fact, mucinous carcinomas can have a score that looks like a really high risk of recurrence, but I just told you that mucinous cancer has a much lower risk of recurrence. So in general, it is not recommended to do the Oncotype DX assay on mucinous cancers. It is okay to do on infiltrating ductal carcinomas with mucinous features. Mucinous carcinomas tend to be estrogen and progesterone receptor positive. Most people are treated with surgery, radiation therapy, and endocrine therapy, but not chemotherapy or targeted therapy. The next cancer I want to talk about is Paget's disease of the breast, or if it's only in the nipple, Paget's disease of the nipple. This is a really interesting condition. It's characterized by eczema-like changes on the nipple, and sometimes that extends to the areola, the area of skin pigmented around the nipple. It's scaly and flaky, tends to be on just one side of the breast, one breast. We don't see this associated with widespread eczema, so if you suffer from eczema, you're at no higher risk of Paget's disease, and it is almost always associated with an underlying breast cancer. It might be associated with ductal carcinoma in situ, which is non-invasive, or with invasive cancer. The way Paget's disease is treated is with surgery. If somebody has a lumpectomy, we tend to remove the nipple and areola complex as well as the involved breast tissue below it. And then that area can be reconstructed so that you can have a nipple. Some people have what's called a central mastectomy, where the tissue is removed, including the nipple and areola. So we don't recommend a nipple-sparing procedure for Paget's disease because the cancer cells are in the nipple and the areola. Most Paget's disease is hormone receptor positive and is generally associated with a very good prognosis. Very few people with Paget's disease wind up having chemotherapy, although it's not necessarily ruled out. Surgery, radiation therapy would be considered, and these tumors are usually not HER2 positive, so targeted therapy against the HER2 protein is not generally part of someone's treatment. If you want to support our channel and you want a personalized report updated with your medical records in pretty much real time, go to yerbba.com. There you can, after giving us permission for accessing your medical records, and it's all done in a way that keeps everything confidential, you can get a personalized report that shows you all the things that have been done, biopsies and everything we know about your tumor thus far. And then your report will give you a list of all the different options you might hear about when you go see your medical team. It'll give you the pros and cons of each of those. This is not to replace your doctor. Your doctor knows you best, and it's not the same as just getting into your portal. Because it's updated with things your portal often won't have, your report is personalized, updated, and it's based on all the evidence that we have from clinical trials, the treatments that might be available to you and offered to you. The next thing I'm going to talk about is metaplastic breast cancer. These cancers look very different under the microscope. Instead of adenocarcinomas, the cells tend to look like spindles. I'll draw that with my finger. They tend to have a narrow end, and then a wide flat end, and then another narrow end. They really look like spindles, like on a loom. These tumors are generally associated with a better prognosis, even though they can look pretty aggressive under the tumor. These are really quite rare. And so it's possible that if you see an oncologist who sees all types of cancers, they may not have a lot of experience with metaplastic cancer. We don't recommend the Oncotype assay because it's not been validated in people with metaplastic carcinoma. They tend to be occurring in younger people, but not always. If you are very risk averse and you want to do everything you can to decrease a recurrence, chemotherapy would be very reasonable. If you are chemotherapy averse, you don't want chemo, well, nobody really wants chemotherapy, but if chemotherapy is not something you can see yourself getting, you're probably on solid ground, though most oncologists will recommend or offer chemotherapy to somebody with metaplastic cancer because these tumors are estrogen receptor negative, so we don't have endocrine therapy to offer. So really, if it's a higher risk tumor, if you want to do everything, chemotherapy might be part of your treatment plan. I'd also like to talk about medullary carcinomas. These tumors occur in about 3 to 5% of people with breast cancer. They're more common they're more likely to be triple negative, and we also see these in people with an inherited susceptibility to breast and ovarian cancer, specifically BRCA. These occur in younger women. They're soft and fleshy. The prognosis is excellent. So the vast majority of people will not have a recurrence after surgery. Chemotherapy generally is recommended because these are triple negative breast cancers. So again, chemotherapy works better in triple negative cancers, and we don't have other options. We don't have other things to offer. So depending on the size and patient preferences, we may very well offer chemotherapy. The next thing I want to talk about are papillary carcinomas. These tend to have a very characteristic appearance under the microscope, like the other unusual tumors I've told you about. They tend to have papilla, which are sort of stalks that form over one another. These are generally considered less aggressive or better behaved tumors. They tend to be hormone receptor positive. It's exceedingly uncommon to have positive lymph nodes or for chemotherapy to be part of the treatment plan. In general, surgery, maybe radiation therapy, and endocrine therapy might be offered. The prognosis is excellent with papillary carcinomas. The last two cancers I want to talk about are a little unusual. Angiosarcoma is a rare tumor of the blood vessels that can occur in the breast or any soft tissue. They are increased in people who've had radiation therapy to that tissue. So in somebody who's had radiation therapy to the breast, again, these are exceedingly rare. Most oncologists have seen these only a few times, and that's if they specialize in breast cancer. They tend to be on the skin, seen first as like a bright purplish lesion that shows up on the skin first. Usually imaging has to be done to check and make sure there's blood flow. The word angio comes from blood vessel, and these tumors are characterized by a tremendous blood supply. So the imaging you can see from the imaging that there's a big blood supply. These are treated with surgery. We tend to offer chemotherapy, but it's different chemotherapy than for standard breast cancer because these are different tumors. They're angiosarcomas, not carcinomas. The last thing I want to talk about, and we have a whole video about inflammatory breast cancer that we'll link here, but inflammatory breast cancer is actually a clinical diagnosis. We can't diagnose it just on the basis of imaging, like mammogram or MRIs or ultrasound. It's associated with changes of the skin, and in particular, inflammatory changes on the skin. So redness and heat and swelling of the skin. The breast may be much larger in size because of the inflammation. We also tend to see a characteristic of the skin called peau d'orange, which is French for skin of the orange. If you think about an orange, it's got that sort of textured, puckered skin, and that's characteristic of inflammatory breast cancer. The other thing is, to be classified as inflammatory breast cancer, the changes on the breast need to encompass most of the breast. So just a little patch of redness is not enough to say this is inflammatory breast cancer. Inflammatory breast cancer is more common in younger people and more common in Black women. We don't know why. Inflammatory breast cancer is considered more aggressive. So it's considered to be more rapidly growing. It's not uncommon for people to have been treated with antibiotics first because it looks for all the world like a skin infection. And so one of the reasons that it may be more active is because it's not often diagnosed early. And in fact, just because the cells tend to be dividing more rapidly, it more likely presents with stage 3 disease as opposed to stage 1 or 2, or stage 4 disease, where there's already evidence of spread to other parts of the body. You know, we used to say that survival was terrible with inflammatory breast cancer, that half the people would die of breast cancer. It looks as though with inflammatory breast cancer, with our current treatments, which are chemotherapy first and targeted therapy if the tumor is HER2 positive, surgery, radiation therapy, and endocrine therapy if the tumor is ER or PR positive, which it's less likely to be, that half of people would have a recurrence. But now with all these treatments, we're seeing 5-year survival rates more like 70%. And similarly, people with stage 4 disease who used to have just a couple years are now living to 5 and even more years. So things have really changed with inflammatory breast cancer. It's still a difficult cancer to treat. And we recommend delayed reconstruction if people are going to have reconstruction. And we always start with chemotherapy first, because without that, it's very hard to get good margins. So inflammatory breast cancer, again, you have to have the skin changes to be diagnosed as inflammatory breast cancer. They have to encompass most of the breast. We don't always feel a mass with inflammatory cancer. A biopsy might be done of the skin. So we do work really hard to confirm it's breast cancer, because occasionally we can be very sure it's inflammatory breast cancer and it truly is an infection. So if you have inflammatory breast cancer and it was hard to diagnose, that's pretty common. Even though clinically it might look all the world, we don't want to treat people with chemotherapy until we really can confirm that they have breast cancer. I've covered a lot. We have videos about nearly every one of these unusual cancers. Again, it can be really hard to have an unusual cancer because it's hard to find other people like you. Yerbba is one great place to find other people who've been through the same thing. You can put in the comments, you know, I have this type of cancer. How are other folks being treated? I'd love to hear comments or questions. If you've had one of the types of tumors I've covered today, tell us about it in the comments. We do try to get back to you within 1 to 2 weeks. We appreciate all the things you share with one another, and your questions are so good. As always, thank you for watching, and we'll see you next time.